Hi there everyone. This is the second video in my series about the New Zealand Heart Foundation recommendations for reducing our red meat consumption. Today I'm going to talk about epidemiology, so when I go through more research papers from the Heart Foundation, they will make more sense. So let's get started. Epidemiology is used in public health research to help identify risk factors. So looking at how health and disease occur in populations. So it looks at who, when and where. And then this research is used to create public health policy. There are two kinds of epidemiology. Experimental is when there are two or more groups and one group gets an intervention, such as a diet or drug, and the other group acts as a control. The differences between the groups are then compared. A common example is comparing a group given a plant-based diet with a control group eating the standard Western diet. Observational studies measure groups of people over time. Cohort studies are prospective, so they follow people with similar characteristics for many years and attempt to identify the risk factors for disease. Whereas case-controlled studies are what we call retrospective. So they look backwards. They find people with a disease and those without, and then look backwards at their behaviours and nutrition to identify risk factors. These studies tend to be large and complex, and both have strengths and challenges. There are a number of problems with epidemiological studies that are important to understand when we're assessing the quality of the evidence. Information gathering is very difficult. Dietary records are used, and these are known to have accuracy problems. People don't always report what they eat, or they can't remember what they ate. It's hard to remember what you ate last month or last week with any great detail. Food combinations also play a role in how food reacts in the body. For example, eating a barbecue steak with a bun, tomato sauce, and having a few beers might react differently in your body than the same steak grilled with a salad and a glass of red wine. These studies can't differentiate between these different factors. Our food also changes over time. The food available today is quite different than the food from 30 years ago. So that's going to make quite a difference in what's recorded from food diaries. And we also make different choices based throughout things that happen in our lifetime. So we might make different choices based on our health, information that we read, and a lot of other factors. Another consideration with epidemiology is that association is not causation. Just because two things may occur at the same time doesn't mean that one caused the other. So shark attacks and eating ice creams are a good example. The more ice creams eaten, the more shark attacks there are. So these are associated. It means both happen at the same time. It can't tell us that one caused the other. There may be another cause common to both. So in this case, perhaps the other cause is on hot days, more people eat ice creams and more people go swimming. Identifying and adjusting for confounding factors are also very important. There is healthy user bias and unhealthy user bias. So if someone has a healthy user bias, they're more likely to listen to health information and follow a healthy lifestyle. For example, they probably won't smoke, they probably don't drink very much alcohol, they tend to exercise more, get better sleep, and often have better socio-economic circumstances, more so than someone with an unhealthy user bias who kind of ignores health advice. I talked earlier about comparison groups, and it's not surprising that comparing the diet of vegans with those who eat a standard Western diet would show better outcomes. To be more robust, a study would compare vegans with carnivores or keto paleo diets to see if it's the diet or the other behaviours that are important. I talked earlier about the interaction of foods, and this is an important confounding factor that's difficult to take into consideration during analysis. How risk is reported is important to understand. Risk is how likely something will happen. So, for example, what is our risk of dying from cardiovascular disease? Risk can be measured in two ways: actual risk and relative risk. The risk of dying from cardiovascular disease, if you're between the ages of 55 and 80, with no risk factors, that means you don't smoke, you've got a good waist to height ratio, your blood pressure is normal, you've got good metabolic health. For men is 5% and for women is 7%. So that's the baseline risk for a healthy person between 55 and 80 with no other risk factors. The actual risk, if you have two or more risk factors, increases to 30% for men and 20.5% for women. So the actual difference is 25% in men and 13% in women. But if we look at relative risk, what we do is we take the people who have got no risk factors and then the people who've got two or more risk factors. And then we work out what the percentage difference is between the two. So the percentage increase in men would be 500%, and the percentage increase in women would be 193%. So this certainly sounds a lot more dramatic when they write those headlines. And this is what is done all the time when media and other groups are reporting on studies. It's also common in drug trials to report relative risk in order to make a bigger impact. So let's take a look at three studies the Heart Foundation referred to in their position paper. So heart disease, those who ate less than 3 servings of meat a week had a 1.5% increased risk of heart disease, while those who ate more than 3 servings of red meat a week had a 1.7% increased risk. And cancer was similar. If you ate less than 3 servings a week, you had a 1.2% increased risk of cancer, and for the higher consumption, you had a 1.5% increased risk. So if we compare the two different ways of reporting on results, we see a huge difference in impact. The actual increase in heart disease, if we use the actual risk, is a 0.2% difference, and for cancer is a 0.3% difference. But if we use the relative risk, then we see a 13% difference for heart disease and a 20% difference for cancer. So these numbers are certainly going to make much better headlines. In the next video, I will take a look at some of the papers referenced by the New Zealand Heart Foundation position paper. Thanks very much for listening.